10. That's the time we start. I can start.
Yep, you can
I don't
start.
have to be nervous anymore.
Okay.
All right. Maybe I'll turn this. Is that okay?
Yeah, it helps.
Okay. Oh, so I'm so glad that you all came. This is awesome, especially those that were threatened. My name's Lisa Pawlowski, for those of you I haven't met, and I am a clinical documentation specialist. So that's kind of one of those terms that makes everybody go, you do what? So hopefully this will make it more clear what I do and why it's necessary that I do it. Basically what I do is I review charts while people are admitted as inpatients and look for opportunities with the wording of the physician documentation that could potentially impact reimbursement and quality. So I'll get going, so maybe that will be a little more clear. Gotta figure out how this works. It was working earlier.
Turn on?
Yeah,
Okay. I don't think it is.
no, it is.
The green, if the green light's on, so it's off.
Maybe it's out of batteries.
No.
Maybe I have to click on, oh, there we go. So the purpose of this talk, what I'd like you guys to take away is to understand DRG-based reimbursement basics. So a lot of inpatients, Medicare and then some private payers are reimbursed based on DRGs. So they're not a fee for service. We don't bill them for everything we do. We get a bundled payment. I'd like to explain how interdisciplinary charting affects reimbursement and CDI efforts and answer any of your questions.
Lisa? Could
Yeah.
you just explain a little bit about what a DRG is?
I will.
Oh.
I know this is foreign language to a lot of people. It was to me. I didn't know any of this until I took this new role, and it was really eye-opening. So Medicare and the other commercial inpatients are paid under DRGs. This is a lump sum payment determined by the principal diagnosis. So when we read through physician charting, and I say we, I mean myself and Betty, have to pick out the reason that the patient was admitted. And sometimes people are train wrecks, and it could be several different things. Sometimes it's not really even clear when they're first admitted why they're admitted, and we have to wait for a few notes. But once we determine this, and it's important to know that this is Betty and I, this isn't a doctor, we translate this into an alphanumeric code. And this is the ICD-10 diagnosis, so it's a letter and a bunch of numbers. And these codes are grouped into DRGs, which is a group of similar codes, and the DRG is what determines payments. So the payment is a lump sum. So they'll say anyone here with pneumonia or respiratory infections gets this much money. So it's the same amount of money whether they're here for 1 day, 5 days, 10 days. Same amount of money. We don't pay, this isn't per day. It doesn't matter what we do to them. They could be in ICU, they could be in med floor, they could be in the hallway for all day care. It's going to be one payment. And this payment can be increased with the addition of the first CC, MCC. I'm going to talk about what these are, but this stands for complication or major complication comorbidity. And these, again, are specific codes that Medicare picked. I don't know how. I sometimes think they drew them out of a hat. That will increase the reimbursement either to the first tier or the second tier. It's also important to know that with the first CC or MCC, someone could have 10 CCs, complications, it's still only going to increase that one level. Or they could have 5 major complications and 10 complications, and it's still only going to go to that DRG with an MCC. So they're still important for quality issues, severity of illness, stuff like that. We still want to show every single one of these, but as far as reimbursement goes, only the first one matters. So the principal diagnosis gives us the DRG, which gives us a weight and a geometric length of stay. So the weight is the most important number. That weight gets multiplied by our facility's blended rate, which is a dollar amount that is determined by Medicare. And that's where they factor in things like our provider mix, our population we serve, quality indicators, PRC scores, all of that stuff goes into giving us a blended rate. And ours is actually pretty high, so it's pretty good. It's 8,000 something. So that gets multiplied by the DRG weight, and then each DRG also has a geometric length of stay. It's not saying they're going to pay for that many days, it's just saying, hey, this is around the time that we think that person should get better results. So DRG weight times the blended rate, that's the 8,000 something dollar, that's amount that's specific to our facility gives us the total payment for the entire time the person's here. Now, they can then go and look at that payment and say, you know, Betty was here for pneumonia, and you did an MRI of her knee, so we don't want to pay for that MRI, so we're going to go take that out of your DRG payment. So that would give us even less than what they pay for a normal person with pneumonia. Complications and comorbidities, kind of talked about already. They have to be documented and discussed by a provider, so they're giving us extra money for these. Medicare doesn't like to give us extra money. So they're going to want to make sure that the doctor is addressing these every single day, and we're saying what we do to treat it. So here's an example of how CCs and MCCs impact what we get for a patient. So if a patient's admitted with pneumonia, it goes into DRG 195, which, you know, you don't need to know, it's just a number, but it gives us this DRG weight. So this is the number that will be multiplied by that $8,000 blended rate for our facility. They say this person should get better in 2.8 days. Once you multiply this by our blended rate, it's $6,669. So that's all we get. They could be here for 5 days, they could go home tomorrow. That's what we get for pneumonia. If the provider also documents heart failure doesn't count as anything. It's still going to be the same. So heart failure, that makes them sick, especially with pneumonia, right? So we want the provider to be specific and give us specified heart failure, which if they say it's chronic, that's the acuity, and the type, which is systolic or diastolic, all of a sudden now it becomes a CC. So that moves the weight up to 0.9 something, and our payment goes up a couple $1,000s. So if the provider documents that there's an acute component to the heart failure, it goes up a lot more. So this chart is worth a lot more than that simple pneumonia. So it's getting the capture of these diagnoses. And we use a lot more resources to treat these patients. So really, we're not trying to take anything more than what we're using to treat the patient. So these are some examples of CCs. I think a lot of you are going to think these are kind of funny. Acute blood loss anemia. A lot of these are kind of more chronic things. Chronic respiratory failure, which clinical indicators for that could be they use oxygen at home. BMI greater than 40. So this is a nursing thing. We get the BMIs from the nurse's notes. So this is super, super important that we get a good weight on admission, that it's an actual weight from the scale and not a stated weight, so we can use this and capture this CC. UTI, acute renal failure, mild, moderate nutrition generally comes from the dietitians, so that's awesome. Cellulitis, osteomyelitis, a lot of times nurses are the ones that catch that too. So we get the doctor talking about that, we get a little more reimbursement. SVT, hyponatremia is a CC, but not a lot of the other electrolyte imbalances, so like hypokalemia doesn't count for anything, but hyponatremia does, which is kind of silly. And nicotine withdrawal. So if you stick a nicotine patch on a patient and mention to the provider about nicotine withdrawal, they document this, we get paid extra. So it's a pretty cool one. Examples of MCCs, these are going to be the big things that I would hope that the doctors are talking about. Pneumonia, acute respiratory failure. So the clinical indicators for this are anyone who's less than 85% on room air or requires greater than 2 liters of oxygen, greater than or equal to 2 liters of continuous oxygen while admitted to maintain oxygen greater than 90. That's a lot of our people, right? So it gets to be one of those things where we're looking for the room air sat. If we have that, we can ask the doctor if they have respiratory failure. If we don't have the room air sat, we don't know if that oxygen's just on for decoration or what. So we're getting in the notes looking for that too. Encephalopathy, this is a term, you know, as a nurse, I think hepatic encephalopathy, that's kind of a narrow margin of people that talks about. But encephalopathy in general is kind of their word for altered mental status. If we can get the doctor to say, we think this is, you know, coming from the brain somehow, that's an MCC, so that's huge. Severe malnutrition, again, comes from dietitians. Staging of pressure ulcers comes from nurses. So we get that from the nurse notes. And present on admission status, super important, especially for these stage 3 and 4. So if we get a good nursing assessment on admission, dressing comes off and they can stage it for us, I mean, that can, you saw what a difference the MCC can make on a chart. It can double the reimbursement.
And
so that's,
can it also penalize us if we don't catch it on admission?
It's huge if we don't catch it on admission, or if we don't document the stage, and it's not clear that this stage 3 or 4 was present on admission, that's a hack. So healthcare acquired infection, they're going to take money away. So we don't want that. sepsis not present on admission, pancreatitis, quadriplegia, those kind of things require a lot more resources, so they're going to pay us more for those. They could have all of these, and we're still only going to get to that one DRG with MCC. So these are not CCs or MCCs. These are the things that I thought were kind of funny. It's like, we don't get anything for that. Chronic anemia requiring transfusion, they don't care. AFib, hypokalemia, give them some potassium, we don't care. The altered mental status confusion, I mean, it's really entertaining to read about a patient that's wearing his pants on the head and walking out to the nurse station, you know, looking for a monkey and a banana or something like that. But it's entertaining, but we don't get anything for that unless it's encephalopathy. Profound hypoxia, respiratory distress, going into detail about how in distress this person is, but not saying acute respiratory failure, doesn't do anything. Alcoholic hepatitis, interestingly enough, doesn't do anything. Heart failure unspecified, chest pain, without a diagnosis, it's just kind of a symptom, they don't care. Syncope falls, you know, they could fall every time they stand up, but if that's all that they're saying, that doesn't translate into an alphanumeric code. So, well, it does, but not one that gives us extra reimbursement. And then O2 dependent COPD, if they don't say chronic respiratory failure, we're not allowed to assume anything. So they could even say low sodium, and we cannot code hyponatremia from low sodium. They need to say hyponatremia. So it's kind of, gets to be kind of crazy. So there's no specific code for these. So there's something like 70,000 ICD-10 codes or something like that, maybe more.
Maybe more.
When you factor in procedures. So there's
70
no
to
code.
80.
There's no code for healthcare-acquired pneumonia. Doctors say that all the time, and they treat it differently than super simple pneumonia, don't they? They get the FANC, they get, you know, the big gun antibiotics, not reimbursed any differently. AFib with RVR, they go to the ICU and get put on a drip, but there's no way to really put that even in the record. It doesn't even count for severity of illness. So that kind of stinks. Acute cor pulmonale, they for some reason don't think can exist without a PE. So there's no way to even put that in the coding system. Uncontrolled, poorly controlled diabetes, unless they say diabetes with hyperglycemia or hypoglycemia, which isn't a CC or MCC, it's just codable, but this isn't codable at all. So, but they have a code for encounters with a macaw versus encounters with a parrot. So it's crazy. And then this isn't the end of it. It's, were you bitten by a macaw? Were you struck by a macaw? Did you have another encounter with a macaw? So you see how reading charts, I could go into so much depth with the doctors, and they would be so annoyed with me that they would run away and hide every time they saw me on the floor. But this doesn't do anything for severity of illness or reimbursement. So this is something I just say, you know, if you want to call it a parrot, fine. So as far as being able to use documentation for coding, this has to come from the doctor, the primary doctor. We can use consulting providers' documentation if the provider, the primary doctor, says, I agree with their assessment and plan. We can't even look at their notes unless we have that in to look at their notes. We can use BMI and wound staging from nursing notes. We can use radiology reports, you know, if the doctor says that they have a hip fracture, but ICD-10 wants us to know exactly what bone is fractured and where, and was it convoluted, or was it displaced, or blah, 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 blah. They want us to know all this stuff that the doctor's never going to say in their note because it would take forever. So we're allowed to go into the radiology reports for that, and to further clarify some diagnoses that are already talked about by the provider in general. But usually the doctor has to document every single thing on here in order for us to code it, which as you can see is pretty time consuming. So when I approach a physician and say, you're saying that Sally has heart failure, but you're given IV Lasix, but you're not saying if it's chronic, or you're not saying if it's diastolic or systolic or acute, so it doesn't go to anything. I have to have clinical indicators, and I do what's called a query. So Medicare is really big on you can't upcode, right? And we can't influence the providers with all of the stuff that we know and say, hey, wink, wink, this is acute diastolic heart failure. We're not allowed to do that. We have to be very transparent in case Medicare ever says, you know, something's fishy here. They were never saying it, now they're saying it on every chart. Like, what's going on? So we have a query form that we use, Betty and I, that we get them to sign that gets scanned into the medical record. And on that form, we'll give them a bunch of different options. we'll put the clinical indicators why we're asking. If it's respiratory failure, I might say nurses' notes say he's 82% on room air. Nurses' notes say he's in respiratory distress on admission, breathing 30 times a minute. Just go in, crackles on the bases, and go into everything I can pull from the chart to give evidence why I believe this person has a diagnosis that the doctor can use. So then he'll pick what they have and sign it, and then it gets scanned into the chart. So then when Medicare reviews it, they'll see the reasons why this diagnosis was called, and then the provider's signature. So anyway, that's a query. That's how I approach doctors. As a nurse, you're used to just kind of turning around going, "Hey, Dr. Knight!" But I'm not allowed to do that anymore. So it has to be very transparent, and I have to kind of follow the rules of coding. That's, not being leading and giving them an out for everything. But when I go to query a doctor, I read all of this information. I mean, everything on the chart that I possibly can to pull those clinical indicators to prove that I am supported for asking them this question. So this is why everyone that gets in the chart, everything is important. And I pulled from every kind of note you can imagine.
So that makes me nervous. So I see pharmacy up there, and I'm like, oh crap, I wonder if we're giving you information that's useful or useless.
Well, and a lot of times for pharmacy, I see that you're consulted and you're calculating a bank dose for renal impairment, but nobody has said anything about chronic renal failure or acute renal failure.
Okay, very nice.
So that's a place that I can look for that.
Okay.
Not every chart do I go to all these places. If somebody's like an absolute complete train wreck like we talked about, I'm probably not going to go to the doctor and say, "I see pharmacy's consulted on the doses. Well, can you give me a acute renal failure?" It's probably the least of their worries. They're trying to keep this person alive. But on some charts, I do need to go there because they're in that low DRG and they're not looking like they're really even sick enough to be admitted. So I've got to find out why this person's admitted and show that they're sick enough so that we can get paid for what we're using to treat them. So we want to be reimbursed for our resources, so that's probably the main reason that they're paying me to do this, to read through the charts and ask the doctors, it affects the bottom line, but it also affects quality indicators and health grades. You never want someone to come in with a UTI and die, and that's all they had was a UTI. That looks terrible. We want to show that, yeah, they had a UTI, but they had encephalopathy, they had a chronic indwelling catheter, they had altered mental, encephalopathy, they had acute respiratory failure, then they got pneumonia, they were sick, they had sepsis, so we want a clear picture once it gets translated into those alphanumeric codes of how sick our people are. So that gets challenging when they have something like AFib with RVR that doesn't really communicate well with ICD-10. So severity of illness, scoring is all based on alphanumeric codes. So if it doesn't code over, they're not going to look that sick for severity of illness. Case mix index is an average of all the DRG weights. So for our facility, and that number shows kind of how sick our patients generally are. And of course, surgeries, the surgery weights are so high compared to the inpatient patient weights because we're using a lot more resources. Like they're using all the surgery equipment and all that stuff. So sometimes it shows more of a mix between our surgeons and our hospitalist patients, but it's an indicator that's used to kind of see how we're doing and how sick our patients are. Legal protection, of course, you would want to document everything. That's common. Risk of mortality, that's kind of the person, we hope they don't die of a UTI. If they're going to die, we want to show that they were really, really sick. So that's kind of a sad way to look at it, but it's also true. So how you can help. I think everyone wants, this is timely, and that everyone wants to do their part to contribute to getting everything that we can, everything that we're owed, everything that we spend. So timely and accurate documentation is the biggest thing. Communicate findings. I mean, even if you're non-clinical and you see something weird, just let someone know, because it could ending up be a CC or an MCC on the chart. If there's a toilet full of blood or something, heaven forbid, you could be the one that catches it. And very important for the patient. I mean, that's the most important thing, is we want to treat them, but it also ends up being important for reimbursement. Communicate changes in patient condition and continue providing me excellent care. So I just wanted to work up sepsis. So this is one thing that I think nursing has a really big impact on, because with the sepsis screens and everything, you're usually the first one to catch it. And generally, if it's early sepsis and they're really sick with the local infection, we're not going to treat it a ton differently. We definitely want to catch it early because it is a benefit to the patients, it impacts how well they do, but it's a huge impact on reimbursement just when that word shows up in the chart. So if sepsis is present on admission, the rule is that that becomes the principal diagnosis over whatever the localized infection was. So it's going to be in a sepsis DRG, not a pneumonia DRG. The sepsis DRG generally pays better, and if it develops during the course of the hospital stay, it becomes an MCC, so that bumps up the reimbursement too that way. So this $10,000 is the difference between someone admitted with simple pneumonia and someone admitted with simple pneumonia and sepsis that was present on admission. So this could be in the ER note, they had a respiratory rate of 23 and a heart rate of 114. You guys know the criteria, a lot of you. It's pretty broad criteria. And to be able to say that this is SIRS and there's a source of infection, so now this is sepsis, that makes a huge impact. To be fair, patients should probably not be admitted with just simple pneumonia. That's something you should go to the clinic and get a pill for. So when they get admitted to the hospital, they usually have pneumonia with an MCC, like an acute respiratory failure. So this is the difference between pneumonia with an MCC and sepsis, so it's still a good amount of money. Someone who comes in with a UTI, again, they shouldn't be admitted with just a UTI, but most commonly it's an older person with a UTI and altered mental status or encephalopathy, which is that UTI with an MCC. And the difference between that and sepsis with an MCC is $6,000. So this is if we can prove that that sepsis was present on admission. So your admission notes, your vital signs on admission, and in the ER are so important. Because even if the doctor doesn't say it, and we can catch this criteria and say, hey, they met sepsis on admission, so then the doctor can go in and say it in his note, we'll get more money for that, without doing anything different as far as treatment goes. Hopefully if they're really septic and sick, it's not going to be an issue when the doctor will talk about it, but we want to screen all our patients just in case. So if sepsis was not present on admission but develops and you catch it in your sepsis screening and the doctor talks about it, simple pneumonia versus simple pneumonia with an MCC is a difference of $6,000 some dollars. And UTI versus UTI with MCC, it bumps it up almost $3,000. So it still makes a difference even if it wasn't present on admission. Generally, we don't like people to get sicker when they're in our care, so it's better if it was present, but it happens both ways. So in review, Medicare pays based on DRG lump sum payments. CDI looks for opportunities to use correct wording so that I can get what the doctors are saying to translate into the alphanumeric codes. And your charting matters because it all gets read, data gets collected from everything. I mean, this was the biggest eye-opening thing to me when I started this job. I thought no one ever read my charting unless I got sued, and I've never been sued. So it was like a free-for-all. And I was embarrassed to meet Betty and realize that someone had been reading my charting. So anyway.
It's all good.
Hopefully I'm making up for it a little bit. But do you have any questions about this?
Do you have any sense of, so if patient A comes in and they have such and such a diagnosis, how does their Medicare payment compare to what it actually costs to keep the patient here?
That's different for everyone. If they're relatively easy to treat and they just have maybe one MC and they get better fast and out the door, Medicare doesn't pay a ton, so I don't want to say we'll make money on that patient. We might break even. They don't pay very well.
The reason I ask is because my experience with Medicare, and I can only do this on the outpatient side because on the inpatient side my drugs get folded into the DRG. Is like for in an oncology center, for example, the difference between a private payer like Blue Cross Blue Shield and Medicare is staggering. So I can get 95% of what I bill a patient through the oncology center if that's a Blue Cross Blue Shield patient. If it's a Medicare patient, I might make $2 on the drug, or I might lose 50. So I was just wondering if it was comparable.
It is very comparable, and this is why, if anyone wants to talk about the cost of care being so high, why am I charged $4 for that Tylenol? This is why, because we're not making anything on Medicare. We are losing money. And this, if you take away anything from this, it's that this system is not working. This is not a good system. This is not built for hospitals to make money. It's not built for hospitals to stay open. Hospitals with a higher percentage of Medicare patients lose money. So it's not really a happy talk, but it's true. And the more people who know, hopefully something will change. Anyone
What is
who
our
brings-
Medicare percentage? What is our Medicare?
That I don't know off the top of my head. Do you have an idea? I'd say it's close to 50%.
Are you talking about the payer mix?
Yeah.
I'd say that's pretty close, isn't it?
And then, we have a lot of self-pays too that you don't even get this on. So we're a community hospital.
And Medicaid.
We're providing a service to the community, and I wish people would see it that way instead of as a profit generator, because there's no way to generate a profit when you're looking at this. I mean, someone who comes in with 5 MCCs is going to be a lot sicker than someone with just 1. They're going to take a lot more resources. And when we're not even really making it back on someone with just 1, I mean, imagine what that does. So, and then you're talking about cancer drugs, why it's such a big deal, why we can't do those big ticket things that aren't related to admission, is because we don't get paid anymore. If someone's here for pneumonia and we decide to go in and aspirate their knee, we don't get paid to aspirate their knee, So,
And the MRI.
and the MRI, yeah.
Do you still have to call the Medicare people when you get a Medicare admission to get permission to keep them?
That I don't
If they
know.
don't meet criteria?
So, do you know that, Lori?
That's the case, okay, I was gonna say, I didn't know if there was a case manager in
Do
there.
we have to call Medicare?
Do you have to call Medicare when someone's admitted to kind of get them pre-approved or
We do not.
approved?
Okay, I was a case manager in another state in 2009, and they had just come up with the ruling that when we had a Medicare patient that came in and they didn't meet SIS, that we had to call a physician, and we had an 800 number. And the physician's office was on the East Coast, and give them the symptoms and the treatment plan, and then they approved or denied. Most of the time they approved, but the Medicare patients had to be in an inpatient setting or inpatient status because they would not approve outpatient observation.
Oh,
And that's a whole nother piece. A lot of times they won't pay for the outpatient bed. They'll just pay kind of for services. That's reimbursed completely differently. The other thing I'd like you guys to know is that Medicare employs, and a lot of private insurance companies, they employ people to look and scrutinize these charts and try to take money back. That's their goal. And the lady who came out to train me actually said that one of her friends had a quota. She worked for recovery as a recovery auditor. She had a quota that she had to pull this much money back each week or whatever.
Yeah, I did utilization review, so I did chart review, and so I would gather the charts, the people that I have to do it on, and I would read through the documentation, the physician orders, the labs, everything that was going on with the patient. And then I had to make sure that they met severity and intensity. So anyway, as say you're Blue Cross, then I would have to call them, a Blue Cross nurse, every 3 days on a patient, if they were in that long, and give them the scoop what's going on, and they either approve or they deny. And so if they deny, then they would send the letter to the physician, and the patient is just at risk of having to cover that. I mean, that's what they always said.
And we don't bill on Medicare, so if it gets denied on Medicare, we eat it. So, but yeah, it's still similar to that. And they have 3 years to go back and say, we're going to deny this. They have 3 years, and they're looking at it after the patient's discharged. So they have all that information. They have way more information than we do. So this system is not set up to work for us. So it's a matter of doing what we can.
It's the idea of don't chart to make the patient look as healthy as they can be. Chart to document their illness.
Yeah, and as a
To
nurse,
keep them in the hospital.
I never wanted to document that someone was having trouble breathing, because I thought that would make me look bad. Oh, he's having trouble breathing, but I went on to the next room, he's fine. But if someone's on 5 liters of oxygen and they're here with this really severe pneumonia, sepsis, acute respiratory failure, they're probably going to be having some trouble breathing. It's okay to chart that, as long as you follow it up with, he's saturating okay, he's not in any acute distress, like he's not going to stop breathing or anything. He's still breathing. He's just obviously not breathing as well as he would be if he didn't have all this going on. That's okay to document. That was hard for me. I never wanted to chart that. So
Lisa, I have another question.
Sure.
Are you seeing a lot of inappropriate services for these patients? So I know that one of my responsibilities is to monitor that DRG and make sure that, for example, I'm just going to pick on Dr. Brown because you like Dr. Brown. So if Dr. Brown's like, oh, I want to start him on Dapto once a day, I'm like, dude, that's a no, because that's a $500 a day dose, and we're not going to get reimbursed for that. You know, but what I could do is steer them towards something else. So I'm wondering for those of us that have, you know, I don't know if we're doing extraneous labs, I don't know if we're doing extraneous this or that.
Absolutely, we are. Absolutely.
Oh, that's bad news.
Yeah, I think all the time, you know, and some of it, you got to do what works for our patients too. We're all here to take care of the patients. But if they're here for pneumonia and respiratory failure, I wish that we wouldn't even look at their leg that hurts, you know, unless it's to rule out DVT or something acute. Once we realize it's a chronic problem, okay, go see your doctor about that. There's no reason that we should do a full workup on something that's not related to the reason they're here or acute. Yeah. So those services, we just, not only do we not get paid for them, but those are the things that Medicare is going to look at and be like, really guys, you can't do that. You can't just do an MRI here. Because now, if they go to their doctor, they're going to want them to go through certain steps before they even get an MRI. So a lot of people think the way around is to get admitted to the hospital and then they can just do the MRI and I won't have to do the x-ray and, you know, all the other stuff.
Is there still that donor code?
Yes.
Lisa, so here's a question. What if we get a patient in, and I think this happened, we may have to look into it. The person was here in 2014, and when they were admitted yesterday, it looked like the 2014 diagnosis, but I was told a whole different thing of why this person was there.
So is this the diagnosis that comes through when you click on the
On the
Quadramed?
overview.
So that comes from, it's my understanding that that comes from the ED tech. So that is not from the hospitalist. It's not anything that I code from. It's just what they say the person's here for. And sometimes it's way off. And Dr. Gerasi would always get curious about that. And I couldn't figure out how to fix
It
it.
doesn't help us if you say you stepped into that and you went, okay, so why are they here?
Oh, it doesn't help at all.
Not at all.
And I actually go in and change that. On my end, I can see it change, not in Quadramed, but in Affinity. When I work up the chart, I change that. But I don't know how to make it talk to Quadramed.
Yeah, it's totally off.
Yeah. But that's what that is. So that doesn't, I won't code off that.
Okay.
Betty won't code off that. We won't. But
So
I
where
know
would you
it's,
find that information in that case? Would you go then to the H&P from the physician or?
yes.
Okay.
So when you read an H&P, what I do, what Betty does, is we try and figure out the main thing that brought the person into the hospital. So if they say, patient came in with nausea, abdominal pain, and in the ER, their room air sat was 82%, we found pneumonia, the reason for admission would be pneumonia. It wouldn't be anything abdominal that was going on. So it's stuff like that. Sometimes you have to dig a little in the words. What I'd like to do is find a way to communicate this information to everyone. What DRG are they in? What's the geometric length of stay? You know, and I think case managers usually know, but to communicate that with everyone I think would be helpful, because it would just sort of get everyone pulled in and say, okay, this person's here for pneumonia, but we're keeping them an extra 2 days because their back hurts. Like, this isn't even related to the DRG, you know, let's work as a team to figure out what's going on here. So hopefully that's something we can do in the future.
I would suggest sharing this particular session with the nurses on the units.
So it'll be available on, she's taping, so I'm never going to watch it, but you guys can watch it. You know, I'll do anything I can. If speaking at a staff meeting would be helpful.
Yeah, I think that would be great.
Do you have plans for the medical staff meetings? Because we need to do this.
You know, I know that that's something I have to do. I'm absolutely terrified of doing
I'll
stuff
go
like
with
this.
you.
So, this was big for me. This took almost a year. So, yes, I do know that's important. And I work better in small group situations. I've talked to a lot of the doctors personally, and a lot of them do understand this, especially the hospitalists, because really the hospitalists are the ones that I would say are the most important. The surgeons get reimbursed. The bulk of the weight is going to come from the surgical procedure. The hospitalists are the ones that really need to, everyone does, but particularly, and if you ever pull up one of Charmaine's notes versus one of, I'm not going to pick on a specific doctor, but a surgeon's, you'll see hers are like way longer than most surgeons because she has to hit every single one of these. So. But yes, I do need to
Charmaine
do
cleans
that.
up a lot of charts after the fact if nobody's ever noticed. I mean, they can be here 3 days and it's pneumonia. Charmaine can come on the 4th day and she will call no pneumonias like previously suggested or documented. I mean, she does a lot of cleaning up. She'll even come on a chart 3 days into a chart and call sepsis that wasn't called on admission, but she'll take it all the way back and she'll say it was present on admission, and then she'll use the indicators of how she came up with that the hospitalists probably didn't go there, you know.
And she
And
comes
vice
from,
versa too.
Yeah.
it
So-
happens all around. She comes from the U of U, and
Yeah.
the U of U has a huge influence on CDI, so she understands this very well. She knows how her words impact reimbursement, so she's like my superstar.
She's awesome, really, you guys.
She understands, because in addition to the DRGs and the codes, we have to establish a POA, present on admission status, for everything, every single thing. So it gets complicated, especially in the case of the train wreck again, who all of a sudden on day 3 has a UTI, and you're like, did we give him this UTI, or did you just not notice because you were doing chest compressions and, you know, all this other stuff the first 3 days, you know?
Or did the order get canceled and now we have nothing?
Yes, exactly.
Mhm.
So that's another thing that I would say is huge, is when there's a UA, and I was terrible at this when I worked on the floor. If there's a UA ordered by the ER doc, I'd be like, sweet, they didn't do it, I don't have to. We need it. We need it, because we need to know if they're gonna get a UTI on day 3, whether that was present on admission and we're just not noticing because they're really sick, or if we gave that to them, because that,
And pneumonias are hard to see because nobody will catch it, and then we get them hydrated, and then all of a sudden, bam. And so we talk a lot about,
and
can you find
Patty's
something?
a huge resource to me, because I'm like, this is what this looked like, will you make sure this is right? Because we never want to show that we're making people sicker, you know. If there's something big wrong with them, like pneumonia, we want to make sure that we gave it to them before we code that as not present on admission. So we're gonna
Something we do
penalize.
give them, and Charmaine will say, like fluid overloaded,
Oh yeah, sometimes we do that, we give everybody fluid.
you know, then
You're
we have
sick,
to
here's a
fix
bag of
that.
fluid, you know,
Yeah.
it happens, but we don't want to get penalized for something that we didn't do.
Right, so I have to answer a yes, no, or unknown on present on admission. Yes, no. If it's totally unknown, I use a U, unknown. And there are no's. I mean, I can't say no when yes when it's not there.
I don't want to take up any more of your time unless you have more questions. I'm not Dr. Brown, I can't talk for another hour.
Thank you.
Thank you.